Namaskar and good evening, everyone. I welcome you all for today's webinar on new age management of prostate cancer. And with immense pleasure, I would like to invite Dr. Triranjan Basu, who is Senior Consultant Radiation Oncologist, SCG Cancer Center, Mumbai, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Mm, Good afternoon. Thank you, CRSF and AstraZeneca for this opportunity. So many of us know this is an ongoing program. So we keep on meeting. So it's one of the another meeting on new age management of prostate cancer. We'll try to keep it more interactive and it's nice. And thank you again that all of you joined on a Saturday at 4 p.m. We'll try to keep on time because I know many of us had some other meetings and it's a Saturday evening. So without wasting time, there's a big change only. Dr. Venkat called me. He is in another meeting. So he will give his lecture after the panel. So we'll do two talks and then we'll do the panel discussion. And by that time, Dr. Venkat will join. So thank you everyone else to join. Thank you, Vedant sir. Sir was actually, I just called sir about just 7 days back. He's kind enough to join these as a chairperson and expert committee member. Without sir, this cannot be done for sure. So just a minute. Just a second. Okay, so we'll start with, I guess, Pooja, we'll wait for a few other or we'll start because Dr. Asha and Gunjan are back to back. So I think we can start.
Yeah, I think we can start.
Yeah, so we'll start with the first lecture of the afternoon. So my dear friend and Dr. Ashay Karpe, who's all of us know him, is a senior medical oncologist and hematologist. So he'll be talking on, are all LHRH agonists same or not in view of prostate cancer? So Ashay, over to you.
Am I audible and my screen is visible?
Yes.
Yes.
Surely. Okay. 1 sec. I'll just make it up. So good afternoon, everybody. It's nice to see Vedant sir, after so many, I think after I left Tata, I'm seeing Vedant sir now. Definitely we have interacted a lot of time during my tenure in Tata Hospital during JCs. And thank you, Triranjan, for the wonderful introduction and giving me these opportunities. Even for me to learn certain things, when actually I was going through the literature. So basically, I'll be just briefly discussing about all are all LHRH agonists the same. So just to give a brief, like prostate cancer, basically what we know that testosterone stimulates the growth of these cancer cells, and ADT or androgen deprivation therapy to reduce the circulating level of testosterone. Either we do that by surgical castration or by the medical castration. So medical castration, what we the commonest agents we use are GnRH or LHRH agonists or antagonists also we use. It widely used in the form of ADT. It's a GnRH, it's a decapeptide from hypothalamus. We have the agonists which are currently available with us is leuprolide, goserelin, triptorelin. Buserelin we are not using that often. And there are some modifications in amino acid residues at position 6 and 10. So the affinity of these LHRH agonists is almost 50-fold higher for goserelin and leuprolide, and it is 100-fold higher for triptorelin as compared to our endogenous GnRH. So this is NCCN guidelines, latest guidelines of prostate cancer, and we can see that in the principles of androgen deprivation therapy. So if LHRH agonists which are approved are goserelin, hysterelin, leuprolide, and triptorelin. We also have anti-androgens along with the LHRH agonist and LHRH antagonists, degarelix and relugolix. So whenever traditionally we have a lot of ADT options which are available in prostate cancer, we have androgen source ablation like orchidectomy, adrenectomy, hypophycectomy. LHRH, LH inhibitions, estrogen, LHRH agonists, progesterone, cyproterone acetate, androgen synthesis inhibitors, anti-androgens, 5-alpha reductase, deutesterate. So now there is so many things which have come up in prostate cancer as of now, that we have options of plenty. And I think more and more these diseases becoming like a hypertension or diabetes, maybe in certain situations. So in the mechanism of action, antagonist versus agonist, when we are using agonist, it stimulates the pituitary LHR receptors, promotes transient release of LH and FSH. Hence, there is a significant increase in testosterone production. It causes a testosterone surge. So that is the reason why when we are using a palliative setting, we sometimes use along with anti-androgens, so that sometimes the symptoms can worsen. There's a gradual decrease in LHH FSH stimulation, and then it decreases the testosterone production. While when you are using GnRH receptor antagonist, it binds and blocks pituitary GnRH receptors, decreases LH-FSH, and there is a rapid decrease in testosterone production. But my talk, I'll be restricting only to LHRH agonists because that is what we are discussing. So as I've discussed earlier, the first injection induces the transient LH and FSH leading to testosterone surge or a flare-up phenomenon. But the chronic exposure to this agonist results in downregulation of LHRH receptors and suppressing LHH, FSH, and therefore testosterone production. A castration level is usually obtained within 2 to 4 weeks. So long-acting LHRH agonists are currently the main forms of ADT, and we have synthetic analog of LHRH delivered as depot injections. Now, when we look at the pharmacokinetics of all these LHRH agonists, the goserelin or the triptorelin or even the duprolide, all these have half-life of around 3.5 to 4.5 hours. So chronic parenteral administration is not possible. Hence, most of these are available as a depot preparations, and that is how we are using it at various schedules depending upon the dose. So we have luprolide, which is available as an implant, microsphere powder, goserelin as an implant, triptorelin again is a powder. Hysterine and buserelin we are not using currently in India. So what is the schedule of the commonest 3 LHRH agonist schedules which we use? Luprolide is 7.5 gram IM every month or 22.5 mg every 3 months, which is commonly we use, or 45 milligram IM every 6 months. While goserelin is 3.6 milligram subcutaneous implant every month or 10.8 implant every 3 months. While triptorelin, it is 3.75 milligram IM every month or 11.25 milligram IM every 3 months or 22.5 milligram IM every 6 months. So all these are more or less can be utilized in hepatic or renal adjustments. Usually they are not much required, and it varies from the administration. It varies for all these things. So is there a class effect among all these available agonists, or can we use different LHRH agonists interchangeably? So if I am using one LHRH agonist and the patient is not responding, or we are not able to achieve a desired testosterone level, can we replace it? The answer is no. And why it is so? So basically what we will be concentrating in next say 10 minutes is about efficacy, survival, PSA decrease, pharmacokinetic and pharmacodynamic properties, safety, tolerability, storage, and convenience of administration. So this was a systemic review and meta-analysis which was published just 2 years back. Whether all gonadotropin releasing hormone agonist equivalent for the treatment of prostate cancer, which was a systemic review, and all these aspects have been discussed. So this is efficacy. Now, this was basically all these studies. They have used a short-acting preparation, which was almost once a month, and now we are using commonly a depot preparation. So, but still, these are very small studies. It's a goserelin versus luprolide, and we can see at 3 months, 26.3%. So the endpoint here was the goserelin for time to progression and for survival and proportion of the patients with testosterone level more than 50. So at 3 months, 26.3% patients in luprolide arm, in 25% in luprolide 7.5 gram milligram arm, and 35% in the goserelin arm. At 3 months, it is 68.4, 30%, 45%. And at 3 months, it is 30 nanogram per DL in luprolide, 9.5 nanogram DL per inch. So the target level of 50 nanogram per ml was able to achieve at end of 3 months. So there was no difference when it was compared from goserelin versus luprolide. Similarly, these are the various studies where luprolide has been compared with the goserelin, and we can see practically they are comparable. Whenever we are looking at the test, whether there is a testosterone breakthrough rate, are we comparing or the proportion of patients who are less than 20 nanogram per DL. So we can see it is more or less comparable. Like in this, we can see the proportion of patient with the testosterone less than 20, the goserelin is 83% versus luprolide 81%. So in the terms of PSA decrease, in the terms of testosterone decrease, in the terms of control, all these are more or less same. So this is another proportion where we are seeing like testosterone. We can look at this at end of 1 month. With the triptorelin, it is 90%. With leuprolide, it is 100%. At 3 months, again, that is with triptorelin, it is 100%. 97 with leuprolide. And at 6 months, it is almost again comparable, 96 versus 100%. So practically, there is not much difference when we are looking at. Again, here, look at the median PSA concentration at baseline. With triptorelin was 46.8 and leuprolide was 36.7, and at 9 months it is almost comparable. It is 1.3 versus 1.1. So what I just wanted to highlight, whether any LHRH agonist we are selecting, basically practically we will have to use how these preparations are available, what is the ease of administration, and what is the schedule which we want to follow. Efficacies, head-to-head large comparison, randomized control trials comparing the efficacy of different LHRH agonists are lacking, and available evidence indicates that broadly the efficacy remains the same. Achievement and maintenance of the castrate level of testosterone. In most of the studies found no or only small differences between this at a castration threshold of 15 nanogram per DL. This is a very small study in Japanese study, where failure to achieve castration level in the patient using leuprolide acetate. This was just 40 patient study was there where they have crossed over leuprolide versus goserelin, and only 4 patients, that is 10% of the patients with leuprolide acetate failed to reach the castration level, while with the goserelin it was almost 100%. What about safety and tolerability? So when we are looking at the safety and tolerability, again we can see here it is goserelin versus leuprolide. It is almost similarly and they are well tolerated. Again, leuprolide versus triptorelin, again we can see the side effects are more or less comparable in all the arms, like 64% in leuprolide versus 56% in the triptorelin arm. Tolerability was deemed satisfactory by 93% of the patient in each group, which is quite good. Again, here we can see at the triptorelin versus leuprolide, and again the grade 1 adverse events are almost same, and there's no significant difference in the body weight between the two arms at the end of the study, and good tolerance at the injection site. So in the terms of safety and tolerability also, all these agents are comparable. So there is short-term adverse effect profile may be broadly similar, but long-term AEs have not been assessed in the comparative studies. Again, what is the convenience of administration? So basically, leuprolide was better tolerated in goserelin was immediately after injection. But this was a particular study where blindfolded patients experienced the same level of pain with the two treatments. Goserelin was quicker to administer than leuprolide. Overall mean administration time of goserelin and leuprolide was 1.7 and 3.34 minutes respectively, which is significantly more nurses express a preference for goserelin injection system, which is 58% versus 42%. We can look at these other leuprolide versus triptorelin. Again, tolerability was deemed satisfactory by 93% of the patients in each group, and patients and clinicians reported greater satisfaction with triptorelin than with the leuprolide. So all this comparison, when we are looking at even the ease of administration, when it's blindfolded, we can see practically there is not much difference while the administration. Again, this is a randomized control trial to determine effect of triptorelin on reduction of prostate volume pre-radiotherapy compared with the standard therapy. Goserelin and triptorelin both caused a reduction in prostate volume and achieved a castrate level of testosterone. The cytoreductive efficacy of neoadjuvant triptorelin was equivalent to that of goserelin. So again, there was no difference even in the neoadjuvant setting. Effectiveness of three different, again, this is a paper which was published in 2019 in the Clinical Urology Journal. Effectiveness of three different LHRH agonists in chemical castration of the patient with prostate cancer. Goserelin versus triptorelin versus leuprolide. And what we can see is changes in testosterone concentration during 9 months of ADT with goserelin 11.34 mg, triptorelin 11.25 mg, and leuprolide 11.25 mg were analyzed. All these agonists showed comparable efficacy for achieving castration when the castration threshold was 50 or 20 nanogram per DL. However, triptorelin achieved the lowest mean testosterone level, that is less than 10 nanogram per DL. So PSA control less than 4 nanogram per ml. So there is no direct comparative data. We have non-comparative trials. All long-acting formulations reduce and maintain PSA level less than 4 nanogram per ml for 1 to 7 years. Goserelin PSA decrease is 93 and 94% for the 3.6 and 10.8 milligram doses respectively. While triptorelin, it was 96% at the end of the treatment for 6 months, while leuprolide achieves 91 to 95% achieved at a PSA decline. Survival, again, there is no difference. There's a comparison of goserelin and leuprolide in combined androgen blockade therapy. It's a 1:1 formulation. They are not significantly different for either of the survival progression. Well, again, this is another study, comparative efficacy of triptolurine and leuprolide in men with advanced prostate cancer. Again, 9 months survival rate, which was significantly higher for triptolurine than the leuprolide, was 97 versus 90.5%. How about the pharmacokinetic and the way of administration? So this was a study where leuprolide was given as a subcutaneous as well as intramuscular. So 1:1 doses of intramuscular versus subcutaneous. And what they found that the subcutaneous levels remained higher for 10 to 20 days longer than the intramuscular leuprolide. And this PKPD difference resulted in the subcutaneous leuprolide suppressing LH and castrate levels of T for a longer period as compared to IM, which is 56 versus 35 days. So the way to administer is also important when we are giving LHRH agonist. Storage. The implant formulation are stored at a room temperature of less than 30 degrees Celsius and are ready to be used at any time. The leuprolide acetate is powder for reconstitution must be kept refrigerated at 2 to 8 degrees Celsius with shelf life of only 8 weeks if stored at room temperature. And leuprolide microspheres and triptolurine powder can be stored at room temperature, but the reconstituted injection must be discarded immediately for triptolurine or within 2 hours for leuprolide if not used. This is one of the interesting thing where there is a practically score JNRH agonist and antagonist in the prostate cancer. This is a system of objectified judgment analysis. It is called the SOJA method, which is applied for the gonadotropin releasing hormone agonist and antagonist in the prostate cancer. It is used for any other drugs, which usually will consider on efficacy, safety, tolerability, dosage frequency. So the selection criteria and weighing for the rational drug selection was weighing was clinical efficacy 300. So these are the point, and out of which each drug scored how much. That was assessed: safety of 200, tolerability 100, dosage frequency, user-friendly formulation, drug interaction was given 60, precaution 60, documentation 100. And these drugs were included in the analysis. We will be concentrating only on LHRH agonist. So these are the drug dosage frequency. For the leuprolide, it was 45 milligram per 6 months, 22.5 for 3 months. So it was almost scored 90%. Again, goserelin also was 90%, and triptorelin was 22.5 milligram per 6 months, 11.25 milligram every 3 months, or 3.7 milligram per month. So the score for the triptorelin was 100%. User-friendly dosages, again, we look at goserelin was again 100%, leuprolide 100%, and triptorelin was 90%. Whereas goserelin was ready to use, leuprolide generics are ready for use, but triptorelin needs to be reconstituted. So this is how the score was given. In the terms of warning and precautions for the GRNH agonist, again, we will be considering on 3. For all this, it is almost same. The glucose tolerance with the goserelin, there is a possible risk. Osteoporosis, everything, I mean, all these have almost increased risk. While doping test can be positive with the goserelin, and lab test acid phosphatase may be increasing temporarily with the leuprolide, and with the triptorelin, gonadotropin producing adenoma may become manifest. While oral anticoagulation with triptorelin, they found local hematoma. So the GNRH agonist SOJA score. So all these points were when considered, like efficacy, safety, tolerability, frequency, user friendliness. So out of this 1000, the highest score was with goserelin and leuprolide. It was 814 for both of these, while 798. So there is not much difference when we are looking in all these 3 LHRH agonists. So whether we want to switch to another agonist, if it can be only for scheduling inconvenience, or is a better testosterone control, or there is a higher testosterone level, if you are finding, it can be because of incorrect preparation or administration or failure of the drug itself. So regular assessment of the testosterone will determine the success of ADT. So these are the EAU guidelines 2021. Although there is no formal direct comparison between the various compounds, they are considered to be equally effective. The different products have practical differences that need to be considered in everyday practice, including the storage temperature, whether the drug is used for ready for or immediate use or requires reconstitution, or whether the drug is given by subcutaneous or the intramuscular routes. This is another systematic review which I've already discussed, whether all these gonadotropin releasing hormone are equivalent. And the conclusion was the studies reporting and efficacy endpoints did not show major differences in the ability of these GnRH agonists to reduce the level of testosterone or PSA. Some studies suggest differences in the short-term or the long-term testosterone control, the rate of injection site adverse events, and the patient healthcare professional perceptions. But these definitive conclusions cannot be drawn from the existing evidence. a few direct comparative trials of GnRH agonists have been conducted. While GnRH agonists provide a similar castration effect, there is not enough evidence to show that GnRH agonists are equivalent. So to conclude, in the published RCTs with the small number of patients, there are no clearer differences in the efficacy between the various LHRH agonists. There is insufficient evidence to conclude that these GnRH agonists are equivalent. A number of practical differences include storage, handling, and route of administration exist between the different LHRH agonist preparations available, which may impact on the clinical practice. It is important for healthcare providers to be aware and carefully consider these differences when selecting ADT for prostate cancer patients. Thank you very much.
Thank you, Asher. It was very informative. So, one question from my side, then we'll ask Dr. Vedant for his expert comment that suppose a patient, most of the time we start with 3 monthly preparation. That is somehow practiced more. Is there something that a patient asks, say 1 year down the line, because for high risk they will take for 2 years, that change it to 6 months. So is it okay to do it? What do you feel?
No, I didn't get your question. Sorry.
So suppose we start with the commonest is the 3 monthly preparation to start.
Yeah.
So you give the neoadjuvant dose, then they receive radiation, then they follow it up, and say the PSA remain control, and then here they ask you switch me to 6 monthly because it's difficult to travel. So is it okay to do that practically?
Yes, I mean, we are doing that often, because the thing is that many of the times what happens now, definitely like neoadjuvant settings, we really rarely come across, but when we are using, especially in the metastatic setting, initially they may be, coming more than frequently, sometimes a month, but more or less when there's a regular follow-up comes, then they try to see, and we reduce the frequency. But only thing is that the studies with the 6 monthly are less as compared to the 3 monthly. If you really look at the studies, the monthly or the 3 monthly studies are more common as compared to the 6 monthly.
Yes. Yes. So Vedant sir, your opinion on that, is it okay to fiddle with frequency, or one should stick to the same frequency?
I think one should fiddle with the frequency based on the needs patient. It doesn't matter, as long as if there's any doubt, just that should do the job.
And another, also not related to this, maybe it is very common with actually Tegarelix, because it goes a monthly in the maintenance. So that is the commonest time people ask, that's please switch. So is it okay to do the switch? Because personally, I am also very confused on that. Because it's inconvenient, no doubt, for someone for a monthly injection to come.
LHRH antagonists, usually I don't fiddle with LHRH antagonists. Agonists is to, because I think we have a more experience. Only situation as of now I'm using LHRH antagonists is sometimes you really required. If you really look at, maybe LHRH agonists may not be same. I mean, Vedant sir can throw better light, but in the terms of symptom control and rapid PSA, the antagonists work much better, especially the Degarelix. And the other thing is that even in the cardiology profile, I mean, see, many of these patients are elderly, and there is no like head-to-head comparison. But if you look at the LHRH agonists versus LHRH antagonists, the antagonists are more preferred in the patients with the toxicity or with the cardiac dysfunction.
Sir, your call on that.
Yeah. So, hi Gunjan, you want to go for it?
No, I don't want to go. Actually, once you finish, I wanted to ask another question. So once you
okay. So the monthly antagonist is really a pain for everyone. When you're trying to switch from an antagonist to agonist, I think that was your question. Also.
Yes, sir. Yes.
So you should really think why you started the antagonist in the first place.
Most of the time, maybe cardiac.
Okay. So what cardiac comorbidity made you start or made your urologist or your medonc start? I have seen people, just old patients, start quickly. Large prostate start antagonist. Metastatic disease started. Rich patients started. Hypertension started. Diabetes started. I mean, are these really indications for an antagonist? I don't think anywhere in the world LHRH antagonists are used as much as in India, especially in large cities. So we really have to ask what is the role of an antagonist and where should it really be used. So there are randomized trials actually that have looked at the benefit of an antagonist versus agonist, and those patients who have what is called as pre-existing major MACE, major arterial, uh, I forget the name, MACE, basically major cardiovascular history. So there, it has to be a ischemic heart disease or a stroke, that history, and there's a score on that. A randomized trial has shown that if you give an agonist, the events in people who have pre-existing history, strong history, in 2 years, those who get an antagonist have 7% repeat events, whereas those who are on agonist, like Zoladex or Leuprolide or triptorelin, palmorelin, they will get it for about 18%. So that's 7 to 18% in those who have a very strong history. So now, yes, there may be some benefit for cardiovascular events, but only in those who have very strong pre-existing disease. And it is not that everybody who has a pre-existing will get a heart attack if you start on agonist, and nobody will get it if you start. So,
if you do.
Yeah, and the pain of the monthly injections, the pain of the cost, the pain of the injection actually itself
Yes.
is quite that these things should dedicate. I don't hesitate in shifting at all. Never.
Right.
Ever.
But the pre-hormonal evaluation of whether it is really that risk cardiovascular to assess and then start.
So what I would do, multiple ischemic heart diseases,
Stroke history.
yeah, then you can start. You can discuss and start that. Look, it's going to be a monthly injection. You have to come every month. And in the traffic, if they come, maybe they'll get the heart attack because of that rather than the injection.
I was actually, sir, you must be aware, I was actually reading a systematic review that even an orchidectomy also predisposes to the same risk. If your initial risk is not high, so it doesn't matter. Like the way it is highlighted, I remember about a decade back when Degarelix came, that cardiac risk, and we as clinicians also want to sway up it in those highlights. So
correct.
Then there's a recent systematic review. Actually, it doesn't matter. Like you said, if your pre-existing risk is really not that high, just because you have a diabetes, hypertension, some past risk of IHD.
Correct.
So even orchidectomy is more risky in those than the medical castration.
Well, that is not entirely true. There is some indication that there may be higher risk with orchid in certain patients, but there's a big push towards, even in APCCC when I was there, there was a big push towards getting orchidectomy back to the mainstream for metastatic patients. You see the cost saving.
Yes, sir.
Because what's the point in doing Zoladex and Degarelix when you not being able to do abiraterone and docetaxel? Rather go for orchidectomy and do that.
The second line
in metastatic, obviously.
Yes, sir.
The other thing I wanted to just make a comment, because I'm the expert, so I have to make some comments. This is for radiotherapy. Now, when we start our patients on ADT, NAHT ADT, it's for short term, 4 months, 6 months, 3 months. And one of the reasons we do that is we want the testosterone to recover after we stop. So that is a very important aspect. And if you look at the testosterone recovery kinetics, there's a big difference between 3-4 months versus 6 to 9 months. So be very careful when you're doing NAHT and RT. Definitely don't exceed 2-3 monthly injections. Try to be between 4 to 6 months. Even use a 1 month injection if required of either Zoladex or Leuprolide or any of these. You do get 1 month injections. So because if you give it for about 4 months, the recovery will happen in about 90% of the people, testosterone recovery, in about 3 months after that. Okay.
Yes, yes, sir.
Whereas if you give it for 9 months to a year, sometimes, ek aur de dete hain, you do continue longer, slightly 6-9 months. Then the recovery goes to almost a year and 18 months, and in only 60-70% of the people. So be very careful. Your whole point of giving NAHT short duration is so that it recovers. Maybe you can use a monthly injection if required. That's from me.
Gunjan, you wanted to ask something before you move to your talk.
Yeah, I just wanted to ask everybody, including sir, that agonist versus antagonist. What is your take when you get a patient with multiple bony mets who has not been, treatment naive patient with an impending cord compression? So, and you don't have much time. You have to start your radiation and you have to start the hormone therapy at the same time. So would flare play an important this thing with your decision to give an agonist versus an antagonist?
Yeah, Akshay, you want to tell?
Yeah, so
Talk about
definitely,
agonist?
yeah. So I said some time back that antagonist, the only two places where I consider antagonist maybe is the where I'm, fearing the flare, number one, where I wanted a rapid control maybe, because definitely with antagonist, you get a rapid control in the terms of PSA and the symptomatic wise also, when there's a comparative study between the degarelix and, yeah. And the second situation, as sir has rightly pointed out, when there is a pre-existing cardiac, it is not that I'm fearing a new cardiac, but somebody who's already had a multiple, say, ischemic episode, maybe cardiac, maybe stroke, and they have very borderline cardiac function, maybe ejection fraction is just 25%, 30%, because many of these patients can have. And these are the two scenarios where I can consider the LHRH antagonist. Otherwise, I'm comfortable with the LHRH agonist.
Gunjan, in the scenario like yours, it is easier to do and quicker to do an orchidectomy. The effect will happen in 48 hours with that also.
Yes, correct.
But if you can't, then you may consider one injection, and then you may want to shift over to an agonist
Orchidectomy, yes.
or an agonist.
Yes. Thank you, sir.
Not only cord compression, but a large prostate with significant borderline urinary function and even a urinary obstruction. Unless you catheterize, sometimes there is a borderline urinary obstruction that can also get precipitated in theory.
Okay, so now it's Gunjan's turn only. So I welcome Dr. Gunjan Bejal. He'll be talking on prostate cancer patient's journey and the JETUC AFU16 trial. So over to you, Gunjan.
Thank you. Good afternoon, Vedang sir and all the esteemed panelists, and thank you AstraZeneca for giving me this opportunity to just share with you some views on this particular seminal trial of GETUG AFU15, which was published in 2016, and subsequently an update has come in 2019 in the ASCO. So basically, if we look at the spectrum of prostate cancer, yes, once the disease goes towards the castrate resistant metastatic
Gunjan, please
subset.
share screen.
I am sharing actually. You can't see it?
No.
Okay, I am actually sharing. It is saying your screen is shared. I'll just try again. Yeah. Can you see me? Can you see the screen?
No.
No.
Yeah.
Okay. So what I'll do is I'll just disconnect and reconnect again.
Yeah. Just 2 minutes.
Hello.
Yeah, can you see the screen now?
Yeah, we can
Yes,
see
sir,
this.
please do the
Yes,
slideshow.
Yeah. So, thank you once again for the opportunity. We'll be discussing this seminal trial GETUG AFU 16. So, as you can see, once the prostate cancer setting goes towards the castrate resistant and metastatic setting, the uh, the survivals and the outcomes of these patients are relatively poor. So, a lot of our efforts in the large spectrum of prostate cancer is to try and keep the disease contained in the early stages, where we use androgen suppression, the radical prostatectomy, and radiation as a very important parts of the treatment. So essentially, for the low and intermediate risk patients, the localized prostate cancers, radical prostatectomy remains an important option for these patients. But the question, perennial question, which has always troubled us is what after the radical prostatectomy. So for a very long time we were with the adjuvant radiation, then we shifted to the salvage radiation subset. But even with the salvage radiotherapy subset, we wanted better outcomes, and as a result of this we started this GETUG AFU 16 trial, which was basically adding on to the standard of care at that time, that is radiotherapy, in the post radical prostatectomy patients who were having a biochemical relapse. So why did they try to add this? Is because they wanted to better on the 50% of patients who after a biochemical relapse benefited from radiation. So they wanted to add on to this. So they tried to see how would adding a short duration of an androgen deprivation therapy, in this particular case Zoladex was used, could benefit the survival or the progression free survival for these particular patients. So what was this trial? This was basically an open label multi-center trial, phase 3 randomized control trial with 43 centers which were recruiting. They included men over 18 years with an obviously a histological confirmed adeno-CA, who had undergone a radical prostatectomy for T2, T3, T4A, N0, or the pelvis was nodes were not addressed during the radical prostatectomy. Very importantly, what they required was that the PSA be below 0.1 microgram per liter for at least 6 months after surgery. So this was a very important subset, and this must be borne in mind when you are actually trying to compare these results with another trial of the RTOG, which did not have this particular subset. So what was the biochemical recurrence was when you saw that the PSA did not stay between 0.1 and continued to increase, and they only allowed those patients to be included whose PSA was less than 2 microgram per liter. And of course, the life expectancy and ECOG scores were quite good for these patients. So what did they do? They randomized the patient to RT alone in such a situation, or RT alone plus a short course of 6 months of Zoladex on the first day of radiation, and then 3 months later, one more course. And in the follow-up, they assessed the PSA every 6 months for 5 years, and biochemical relapse was considered as 2 consecutive rises in the PSA level with a nadir of above 0.5 microgram per liter. And if there was any progression, they also assessed it through the radiographical assessments. And quality of life assessment with the ADT and without the ADT was done at randomization 1 year and 5 years, and 5 years, and then at the end of RT. So what were the basic endpoints? The primary endpoint here was progression-free survival. This is important to understand because these patients which were taken into these trials were basically a good prognostic sort of a group. So the expectancy that there would be a lesser number of metastatic events and a lesser number of deaths due to the survival would not be so much affected due to this. So that is why the overall survival came into as a secondary endpoint. So what did we get when we went into the study is that we randomized these patients. There were approximately 700 plus patients taken into the study. which were taken into the radiotherapy alone arm and the radiotherapy plus guzarelin arm. Both the arms were, almost well balanced. Less than 8 Gleason score was the larger chunk of the patients in this group, and the PT4 group, that was an inclusion criteria, was not very commonly seen in either of the subsets. The T3A and the T2 lesions were the biggest contributors in both the arms. Almost about 20-25% patients did not have nodes addressed at the time of their surgery. As a result of this, later on, modification in the protocol had to be brought in, where when we were giving the radiation, about 15 to 17% of the patients in both the arms received pelvic nodal irradiation to a dose of 46 grays as well, and the prostate bed received a median dose of 66 grays in both the arms. The follow-up for this particular subset was about 5 years, and yes, the PSA at randomization was definitely less than 1 in almost 90-95% of the patients, so which was very important to this particular trial. So when we assess the results from the primary endpoint perspective, we see that at the end of 5 years, the RT alone arm had a progression-free survival of 62%, whereas the RT plus Zoladex arm had a PFS of 80%. Therefore, there was an important difference by adding this short-term Zoladex to increasing of the progression-free survival. There was no impact on overall survival at that point in time, which was seen at that particular point in time. If we see what were the major side effects due to the addition of the guzarelin in the radiotherapy plus ADT arm, it was basically the hot flushes and sweating which dominated. About 6% of the patients had some kind of hypertension, but beyond that, all the other side effects were very much, within manageable limits. And this can be seen in the quality of life assessment at 1 year and 5 year, where there was not much difference between the thing. One of the limitations said is that the QOL was not done at about 6 months when the ADT effects had peaked. And actually, that's what I think Dr. Vedang was also trying to say initially, that once you give that second dose, it takes about 3 to 5 months to 6 months for the testosterone to recover. And as far as addition of the Zoladex to radiation-induced toxicity, there was not much difference between the two arms, and addition of the ADT at 1 to 5 years did not compromise on the sexual function of the patients as well. So, in a nutshell, what did we see? That if we add guzarelin to the salvage radiotherapy, the addition increases the outcomes from 62% to 80%. Progression-free survival is increased. So this was better with regards to the biochemical progression or clinical progression for these particular patients, and even the hazard ratio of these particular things was in favor of the addition of the Zoladex. So this was the first phase 3 trial that specifically studied the patients with an undetectable PSA after surgery that subsequently began to rise and show the benefit of the androgen suppression when added to salvage radiotherapy. So when they did this study at about 9 years follow-up, and they published it in the ASCO, they presented it in the ASCO, we see that this 5-year PFS continues to increase or remain stable in the Zoladex arm, and that gap that was there initially is continuing to be maintained. So men with a biochemical relapse following a radical prostatectomy have a 46% reduction in risk of disease progression when treated with, or Zoladex is added to the radiotherapy compared with those treated with the radiotherapy alone. And the benefits seen with guzarelin for 6 months in association with RT compared with those treated with RT alone were independent patient risk subgroup for low high risk patients respectively. So this metastatic free survival was also significantly improved in the combined arms. So after all this study, the researchers concluded that the salvage radiotherapy combined with short-term hormone therapy can be considered as the new standard for the salvage treatment after radical prostatectomy. So in this particular subset, actually what is important is not this definition of the locally advanced cancer, but to bring into perspective is that one must understand that there is another trial of the RTOG which actually takes into consideration a similar subset of patients in the post radical prostatectomy subset, and adds on 2 years of bicalutamide therapy for the patients. But if you look at both the trials, they are slightly different from each other. In this particular trial, basically what we see is that the T2 to T3 group was pretty high. But this particular trial, what we have seen is that patients always had a gap of at least 6 months to failure, which was not there in the RTOG 9406. And in fact, the baseline PSA at failure is, or if you can get the interquartile range, the interquartile range of this GETUG trial is actually very, very small. It is between 0.2 and 0.5. While in the RTOG trial, they allowed the PSA rise to be a little more. In fact, if I recall correctly, it is greater than 1 is the upper range of the interquartile range, 0.4 to 1.1 if I remember rightly. And in fact, it not only here the trial limited the accrual of patients at the level of 2, but the RTOG allowed it to go up to 4. So, and then after giving this bicalutamide for 2 years, what they observed is an improvement in the overall survival, distant metastasis free, and this one, especially in the groups where the Gleason score was high and a PSA of greater than 1 was there at failure. So what do we infer from both these studies? Can we say that this group of patients post radical prostatectomy is an uniform group of patients and we should just apply the GETUG findings to all the patients, or can we actually even here subdivide? So what I feel, and I will leave it open to other panelists to contradict me or to tell me better, is that whenever I get a patient, I would like to see so many other things which determine this failure. For example, the initial Gleason score or the PSA doubling time and the interval to biochemical relapse. For example, if we get a classical patient who has a high Gleason score with a high who at failure had a PSA of 1 or more, probably I would be inclined to use the 2-year hormone therapy in this particular patient, while another patient who has had a radical prostatectomy and with a margin positive as well, but has been in biochemical remission for 7 years or 8 years, for such a patient, probably at the time of failure after 8 years, I would probably not resort to any kind of androgen deprivation therapy and would simply give him a salvage radiation. And for all the patients in between these two wide subsets, probably these are the patients where we can apply the findings of this GETUG trial and use the shorter course of the androgen deprivation therapy. So this is that's what I had to say. With that, I would like to conclude this presentation. And this is a short description of the prescribing information for Zoladex, which was the ADT used in this particular trial for patients. Thank you so much.
Thank you, Gunjan. So I feel even the Capra score would guide better, because other than this, there's radicals RT in race trial also. So salvage RT is quite in thing now. And Capra score is a good one to highlight. So I'll come to Vedant sir, but I want to ask, I can see everybody is there, the neurosurgeon. So how comfortable you guys are, Dr. Anirudh, Dr. Saurav, Dr. Santosh, of sending for immediate adjuvant or maybe discuss and wait for salvage? What your take is? Yeah, hi, Dr. Santosh.
So, as rightly said, this happens during the counseling part. And when the counseling is being done, the patient is being given a broad idea of what they should be expecting after their primary therapy. And yes, we are rather comfortable sending the patient for adjuvant if that is going to improve his outcomes. If the patient is counseled well, then that should not be a problem. That's what I feel.
Dr. Saurav, your opinion?
Yeah, hi, Chiranjan.
Hi.
So basically, regarding adjuvant and salvage, I feel current data is also towards salvage. And depending upon whether semanovesicle is involved, more than 4 plus 4 Gleasons and margin positivity. If two criteria are there, I would definitely go for adjuvant. Otherwise, I would wait to monitor the patient with PSA after 6 weeks and after 3 months from surgery and then take a call.
Okay, Dr. Anirudh, your opinion?
Yeah, hi.
Hi.
Yeah, even I agree with Dr. Saurabh that I would rather wait for 3 to 6 months before taking a call for giving adjuvant, because many of the patients do respond to initial therapy for quite some time.
So early salvage. Okay. So I'll come to Vedang sir. So this is quite common, even if all the other risk factors, say the post-prostatectomy PSA is in biochemical control, like less than 0.2, and nodes negative, because node positive is a separate cohort altogether. All trials have, irrespective of the node things. If nodes are negative and PSA in biochemical control, so sir, should we really advocate salvage in today's time? Because some people would be able to maybe skip radiation.
So, Triranjan, I think what Gunjan was speaking was not adjuvant versus salvage, first of all. He was talking about the use of ADT during salvage radiotherapy.
Yes.
So, I think that is the point of discussion, should be the point of discussion right now. We can keep talking about adjuvant versus salvage till the cows come home. But I would agree that I mean, our surgeon colleagues have just said higher risk CAPRA score. I think adjuvant still has a role, but if there is one risk factor or no risk factor, and patient is good for monitoring, salvage is a good option. But early is the key word.
Yes, sir.
And early doesn't mean two things. Early doesn't mean start ADT and then be happy that nothing is rising. And early doesn't mean 1 or 2 PSA. It means 0.2 or 0.3 or 0.4 or 0.5, not beyond that. So these also, while we are at it, some patients do end up getting an ADT before surgery for whatever reason that happens in the community. There is no evidence for that, but it does happen sometimes. The problem with that is it will influence your post-operative PSA. And as we discussed some time back, it takes time. The testosterone takes time. So make sure you ask if they've had an ADT injection before the surgery sometime, and wait for testosterone recovery before you start deciding about the TSA. So that is an important point in practice. Now, coming to Gunjan's talk about the use of ADT with salvage RT. Now there is a third trial that has now come in the picture very recently, called the SPORT, that was reported in Lancet about 2-3 weeks ago. There were 3 arms. One was ADT alone, one was ADT plus RT alone, salvage RT alone, salvage RT plus short course ADT, exactly like the JETIC trial. And there was a RT plus short course plus pelvic RT. And there's a whole lot of discussion again about that. But again, that adds to the literature on the use of ADT with salvage RT. I think there is a role for short course RT, short course ADT along with salvage RT, particularly if the PSA is on the higher side. From the RTOG trial that Gunjan said, they were much worse patients, more advanced, higher PSA, and the benefit was really seen overall survival if the PSA was more than 0.7 actually. Under that, there was no benefit seen. And here also, there's no overall survival benefit seen. So a lot of people are saying, do we really want to give patients 6 months of ADT just for a failure-free survival? So if say Santosh or Saurabh, they have sent a patient very early, 0.2, 0.3 rising, you can avoid the ADT actually. Go with prostate bed, add the pelvic RT based on the sport, and avoid ADT. ADT is a killer. I mean, ADT is bad in general. So we would want to avoid it. You give it for 6 months, patient's testosterone knocked out for a year, and that is a long time in somebody's life. So, and you reduce the testosterone for a year, of course, the PSA will be controlled for 1 year. Of course, it is going to happen. What's the rocket science in that? So avoid ADT if the PSA is low, risk factors are not there in terms of high Gleason. And to put all of this in context, we really don't know. We really don't know how all this is relevant when we do PSMA PETs. None of this is PSMA PET based. So Triranjan, you get a patient 0.4, okay, biochemical failure 0.4, 0.5. You done a PET scan, it's negative. We do a PET scan, don't we? It's
Yes,
negative.
Yes.
Then what? Then is there a role for giving ADT? Surely you have to give RT because PET scan is not going to pick up microscopic disease in the pelvis or distant. It picks up macroscopic disease. So you're giving radiotherapy for microscopic disease. And does ADT help? No one knows. So especially in the PET scan patients, especially if it is lower PSA, avoid the ADT. Higher PSA, sometimes patients has not come, has not been referred. PSA of 1, PET negative. Do the RT and add the ADT, but add it for a longer duration. That is my summary. I can go on and on and on, but I'll leave it at that.
No, thanks. It's two very valuable points. Yeah, actually, all these contemporary trials were not PSMA stage 1. And I guess the recent sport also has highlighted the add to the literature, like sir was saying, for the hormone, and also added to sir's own publication of the volumes of RT, the bed with the pelvis. So that was a good takeaway from it. So
yesterday we had, I don't know if you saw yesterday, there's a Red Journal paper, one more. From
yeah, I just saw. Yes.
Saw that.
Yes.
Okay.
Yes.
Okay, fine.
So, Moin, can we start the panel because
Yes, sir. Yes.
Dr. Vivek will be able to join by 5:15:20. He sent me a text, so we can finish the panel and he can then give his.
Sure, sir. Sure.
Okay, so just share the screen.
Triranjan, if it is okay, I will leave. Moin, is that okay now?
Yes, sir. Yes.
Thank you so much, sir.
Thank you so much for having me.
Thanks, sir. Thanks,
you guys can have a thanks. Thanks all of you.
Sure.
Thanks, Santosh.
Thank you,
Bye.
sir.
Bye, Gunjan.
So just a minute, I'll just. Okay, is the screen visible? I think the slides.
Yeah, it's visible.
Yeah, it's visible.
Yes.
So thank you, everyone. And sorry, I couldn't add up questions much. Both Dr. Saurav and Dr. Santosh asked me. And so I told him we'll keep it an open discussion. So Yep. So since sir is not around, so this is a very ensemble panel. I welcome you all. I guess Dr. Saurav Patil, Dr. Anirudh Gokhale, and Dr. Santosh Vaigankar is our neurosurgeon colleagues. All of them are here, I think.
Saurabh is not there.
Saurav told me to join. Okay. Then from as Holi's joined and Dr. Advait joined.
So Dr. Advait would be joining in some time. Dr.
Okay.
Holis also is trying to join, sir, in 5 to 10 minutes.
Okay. Okay. So they are our medical oncologists, and Dr. Sandeep and Dr. Pranav joined. Both actually send me a text. They're stuck in something.
So they will also joining in 5 to 10 minutes. You can start.
Okay. Okay. Asha, you're around. I think he is not around. Anyhow, okay. So this is basically, once I went through the slides, it's basically one case and there's some ramifications related to it. So the case is a 72-year-old patient presented with back pain to a spine surgeon, had multiple comorbidities and one CABG in 2004 with no urinary symptoms. A spine X-ray suggested a lumbar canal stenosis, underwent spine surgery for the same, and there were no biopsy or no PSA done for whatsoever reason. So I'll start with Dr. Santosh and Dr. Anirudh. Is it common for you to see still this now, that no biopsy or no PSA? Or was it right because there were no urinary symptoms and it was an emergency, maybe of orthopedic magnitude?
Okay, so Anirudh, you want to go ahead?
No, you start. You start.
Okay. So Tiranjan, it's definitely unusual, but what happens is this patient has presented directly to the spine surgeon and with a 72-year-old age and with presented with a backache. They would probably think of more of spinal pathology here, and the first thing would not come to their mind would probably doing a PSA, or unless he mentions of any urinary tract symptoms. So yes, it's not uncommon to see such a scenario in our daily practice where a patient comes with a symptom, a backache, but a PSA is not done, leave alone biopsy.
I would like to add that in this case scenario, it is written that spine X-ray shows lumbar canal stenosis, but I presume that nobody would operate without any MRI. And probably if the MRI has not shown any suspicion of any metastasis or anything, I don't think, I mean, he is justified in not doing a PSA at this point.
Yes, yeah, very true. Yeah, even I was reading that maybe it's just to create the flavor of the case. This was put, yeah, at an MRI spine been done, definitely would have picked up at least something. So which would have, though maybe we see definitely many times that spine MR is a very limited region of interest. So that might also miss, but yeah, there were no urinary symptoms like both of you said. It was of a different emergency, so it was not done. So then what has happened is that so then after about 2 years develops obstructive lower urinary tract symptoms and a recurrent of backache, and meets a neurologist and founds a hard prostate on DRE, and at that point the PSA is 86. So at that point also there were bone scans done and showed 2 hotspots in lumbar spine. Biopsy suggested Gleason of 4+4, and MR had no nodal or visceral disease. So before I go to the last line, so I really want to ask this because as neurosurgeons, this is something you are seeing more. Is it really very significant to do a DRE in today's MRI era?
I think the Tiranjan, DRE is absolutely important. It needs to be done because MRI comes later after the patient has consulted in your consult room. So when the patient is with you, a DRE is absolutely needed, but that is not the only one which would help you to reach a diagnosis. But DRE is something which cannot be missed because at this point of time, we don't know what is the stage of the disease. And a DRE definitely gives us a direction, as I mentioned here, that a hard prostate on a DRE would ring bells and would make us believe that it could be something more notorious than what we are thinking. And with a PSA of 86, patient already being in a high risk category, and the chances of having mets are definitely there. So I think DRE is something which should be done in whichever case possible.
Yeah, correct. I also agree with
Saurabh,
Dr. Santosh.
you reached home. Okay.
Yeah, sorry. I am sorry for the.
No, it's fine.
So I agree with Dr. Santosh, and not about this case, but most of the times in Indian scenario, patients do have some baseline chronic prostatitis. In that case, PSA may be misleadingly, falsely high. But once you put a finger in rectum and get an idea about the feel of the prostate, then you are almost sure. So it has to be an integral part of examination. We cannot skip, irrespective of whichever modality we use, whether MRI, PSMA, PET CT. But DRE has to be there.
So yeah, that's a good point. I wanted to bring this out. In one of the meetings some days back, actually someone spoke about it, that why we have to do something like DRE. We can straight away see the PSA. If its PSA is high, you get an idea whether it is turning out to be an intermediate or towards high, and do an MR. So why you want to subject someone to a DRE like thing? So yeah, it is very important that yes, there are other pathologies which can be coexisting.
Correct. And apart from oncological point of view, for us as a surgeon, we can also get an idea about the anal tone, which is important for us for explaining him about the post-operative continence recovery. So we cannot skip this with whether it is relevant to oncological part or not. It is very important.
So then the biopsy done, and this patient MRI suggested no nodal or visceral disease. So I'll ask, is Dr. Advait around?
No, sir, not yet.
Okay, so then we'll limit between 4 of us. So between 3 of you, that do you think it was right in today's time seeing a PSA high risk, 1 factor high risk met up, biopsy high risk met up, 4+4 to just rely on MRI? I don't know what it is mean for MRI for visceral disease, or for that matter, nodal would be also only local. So I suppose a PSMA should be standard in this. Any doubt on that?
No, PSMA is the accepted standard.
Because it is already high risk. In 1 factor meeting up, it is high risk. So,
so in fact, I would skip the bone scan and straight away ask for a PSMA scan, PSMA PET.
So because for us as radiation oncologists, once we see, if you ask me, my personal advice is always better to do a PSMA, because bone scan I'll do, it may be an improper staging. I'll have no idea about pelvic node. That upstage happens in 15 to 20% cases for high risk. And with the treatment paradigms changing, I feel one should do a PSMA. That moment you're seeing high PSA and the Gleason grade group 4 onwards, it is better to do PSMA, right, Dr. Santosh? Because I feel that's a one-stop solution for multiple visits.
Absolutely, because you're talking about not only the nodal, the skeletal, but also the visceral disease.
Also the visceral.
As you said, one investigation will give you information in all these aspects.
So this patient, whatever reason, was based on MRI staged and started on hormone. And the slides, yeah. So of course, the initially backache disappeared, urinary symptoms sorted, PSA was 1.9 in about 8 months, and then developed obstructive urinary symptoms and urinary retention. Also failed catheter twice. So it's a very locally symptomatic patient for that point, though we are not sure about the initial staging itself. Developed refractory urinary retention, 100 gram of prostate, and then a PSMA was done, which suggested lesions in the prostate in L2 and L5. By the time the backache was sorted somehow. So that's coming to the next, these treatment options. So is it really, my first question would be, is it really to call it an oligometastatic disease? Because we're not sure only since when the disease evolved. So what is your take on that?
Triranjan, one point I wanted to add was this scenario usually seen when these patients come from periphery. I think my colleagues will agree. And it's also important to understand the accessibility to PSMA PET in this era. these usually patients do undergo bone scan even today, where PSMA PET CT is not available. So I'm sure that because the bones, because the the bone scan showed a metastatic disease, the sort of treatment was started. I think that's what you wanted to ask, right? So, and when the patient was probably referred back, a patient developed a symptom of retention. He wanted to go to a higher center, and there where PSMA accessibility was there, and that's where the PSMA was done and the lesions were picked up. So that's what my understanding is of this case.
Right. So I think Dr. Pranav and Dr. Sandeep, they joined, both our radiation oncologists. So what is your take, Dr. Pranav and Dr. Sandeep, that should we call it really oligometastatic disease? Because we're not sure. I'll just brief. This patient started basically with a low back pain. It's just started with a low back pain some time back, some years back, and evaluated through a spine surgeon, and there were no LUTs at that point. So I had some spinal decompression surgery and everything, and eventually after years down the line, the local symptoms started and staged by MRI, and then started on hormone. So eventually, initially hormone responded, PSA dropped from about 80 plus to less than 2. Symptoms started resolving, eventually again symptomatic, and this time PSMA showed prostatic lesion with L2 and L5 deposit. And then this slide is being shown. So is it really, can we call it oligomets? Because the first line staging is not appropriate maybe, and we are also not sure from what point the disease started.
So Triranjan, 2 points I would like to highlight is, the thing is that you are absolutely right that if we leave aside the vertebral biopsy, which happened a long time back, so this is a new symptom, right? This is a new symptom, but definitely the workup was not completed. But having said that, you were just mentioning about PSMA PET scan. There is no clear-cut guidelines given by the different bodies. You call it European Urologic thing or NCCN, whatever, about the use of the next generation imaging, that is PSMA PET scan. So you will need to keep that in mind as well.
Dr. Pranav, your call.
Yeah, so exactly. So NCCN guidelines put up as F11 choline, if you see the guidelines, and PSMA is mostly used for to detect when there is a PSA rise, especially in early prostate post-surgery. And also, as per, if we are defining the oligometastatic disease, we have studies in which, if I'm not wrong, Chartered did not use a PSMA PET CT for the initial staging, if I'm not wrong. I would like to call it as oligometastatic disease with number of bone lesions, if I take the L2 and L5 as less than 5, or less than 4. The visceral, there are different definitions, but at least this patient, I would like to treat this patient as oligometastatic, give the benefit of doubt.
So depending on whatever definitions we go, begin with Stampede or Horror, followed by the Chartered definitions. If there are no visceral less than 3 to 3, some people call it 5,
4, 5.
So then it can be staged as oligometastatic.
Yes.
Ranjan, I just have one doubt. Just to play a devil's advocate, what I wanted to ask is, what if this patient has presented with 7 METs? Because the PSMA PET scan was not done. It was a bone scan which is picking up the MET. He's been given Zoladex, and after 2 years, you're getting a finding of 2 METs, which is making us believe that it could be oligomet. So that is another thing to think about also.
Exactly.
I'd like to hear the views of other panelists as well on this.
Yes. So then it's no, because that's the point I wanted to make, because we are not sure how the disease started, at what point it started, because the first staging investigations were not complete only. So and that is a typical difficulty. Even we all work in Mumbai, but I guess we all still face these kind of scenarios. I have seen even in Mumbai people have such improperly staged disease, and then I feel the biggest challenge is that because patients feel now they are less symptom, their PSA is okay, so it is a it is a treatable disease. It is a local disease that can be managed. But it's difficult to counsel that the overall it might not change anything to the outcome, even in this point. But yes, I agree with Dr. Pranav. Eventually, probably will end up calling it to be oligomets and trying to treat, because there's no point now going back to the what is not done properly. But yeah, I guess
I would just like to make a point here. The PSA at diagnosis was 86.
Yes,
it's a very high.
And oligomets with a PSA of 86, I would be thinking twice before calling it as oligometastasis. Because PSMA was not done at that point.
So PSMA not done is the challenge, but otherwise the PSA cutoff definition.
High PSA, huh?
No, but the PSA cutoff definition, if you go by the horror trial, is 140 actually. For horror trial to call it a low volume oligomets, they take up to 140 the PSA level. So, and if it are assuming oligomets, then maybe expected, because for high risk also at times we see people, though there are studies which quote that beyond 50 PSA, even if you're not seeing metastasis, they maybe are M0 basically. But we do see, I guess Dr. Sandeep and Dr. Pranav would agree, we do see these level of PSAs with no metastasis, even in PSA.
Right.
Or maybe with a concurrent prostatitis, you might be getting an elevated PSA. That is how, maybe, I don't know. That is how.
So at this point, since I'll just go back to the previous slide because you'll get it. Yes. So patient had obstructive urinary symptoms with retention, twice catheter failed, with refractory urinary retention, and all these as per local symptoms. So at that point, I'll start with the our urosurgeon colleagues that would you do a channel TERP and then take a call, or you're okay, continue hormone or send to us?
So now, Dr. Thiranjan, at this point, basically patient is expecting two things. One is cancer control and one is, am I audible?
Yes.
Yes.
Yeah, so basically patient is expecting two things from us as a clinician. One is cancer control and one is local symptomatic control. He wants to get rid of this catheter thing. So we have now maybe three modalities to offer. One is he is already metastatic, whether it is, we call it oligometastatic or widely metastatic. He is already metastatic, and like you will all agree that now standard of care has been shifting from only ADT to ADT plus some systemic therapy. So we have to start along with ADT some androgen receptor antagonist.
Exactly.
Secondly, for local cancer control and local disease symptomatic control, two things are different here. So for cancer control, we have two options of doing radiation therapy, SBRT, or radical prostatectomy. I'm not a very great fan of radical prostatectomy here in oligometastatic setting. So I would definitely refer this patient to you. But I will make sure that he should get rid of this catheter thing. So I'll perform channel TRP and then we'll think of doing radiation therapy.
Okay, Dr. Santosh, your opinion? Surgery for the local.
I agree with Saurabh. The two things I want to add is, one is you need to see the patient symptom. The patient is symptomatic not for his bone mets but for his urine issue. If the patient had bone mets which are painful, then I would probably defer doing a TRP right now, because that will delay the radiotherapy by some time. I think my radiotherapy colleagues would comment on it. Doing a TRP followed by radiotherapy, would they be happy with that? Or doing a radiotherapy and treating the painful mets and doing a TRP later? That's one point. Second, about radical prostatectomy, we see that the trials which are there, retrospective trials, they are more of hypothesis generating trials than practice changing trials. So definitely radical prostate is not something which would be offered to this patient, but channel TRP, a decision will be taken depending on the bone mets. But in this scenario, since it is two spine lesions which are not symptomatic, I would definitely go for a channel TRP as suggested by Saurabh, along with addition of androgen receptor antagonist.
I have a point, Dr. Santosh, just to think that in a lot of patients, we do see that once we start.
So your voice is very low, sir.
Is it? Am I audible now?
Yeah.
Yes.
Yeah, in a lot of patients, we do see that once we start the ADT plus ABI, the urinary obstructive symptoms come down. So wouldn't you wait for some time and then think of TURP after again reviewing the score and then take it up, or you want to do it upfront?
Again, that depends on two things: the patient acceptability. Some patients don't want the catheter to be there, to be very frank, and this is what happens at ground zero level in our cabin. They don't want the catheter to be there. Secondly, the size of the prostate. We have a 100-gram prostate here that we're talking about, and I don't know how. I'm frankly, I'm not sure about how long I can wait in a 100-gram prostate for the obstruction to be relieved without a non-surgical intervention, only dependent on ADT. So I would definitely go for a TURP in this case. Just channel TURP to relieve his symptoms. That would be my approach.
Yes.
So I want to interrupt and ask here that I also get confused at times, because suppose we see these, that the patients visit you guys as neurosurgeons and come to us because if there's a radiation opinion. So is there a clinical judgment, a sort of say 1, 2, 3 points that, okay, you have to do TURP immediately, or like Dr. Sandeep is saying that, okay, you can wait, see your hormone response and take a call? Are there really these clinical pointers?
See, as Dr. Santosh said, prostate size and patient acceptability are the two main things. Secondly, in this scenario with a 100-gram prostate, even studies have shown that in spite of adding anti-androgens, the decrease in size in the prostate will not be more than 20 to 30%. And which is not enough for him to be voiding normally. So I would be inclined towards doing a channel TUR in such cases, except in cases with a very small size gland. I will consider waiting for a few days more, but at least not in this particular case.
Correct. I also 100% agree with Dr. Santosh and Anirudh sir. And here there is, as such, there are parameters to say that this will work or we can prolong. Only thing is, rightly said by Dr. Santosh, that patient acceptability. In this case, we have already given him trial twice or thrice, I guess. So I think waiting for long would unnecessarily irritate the patient. And in few scenarios when there are kind of bilateral upper tract changes or dilatation, along with the creatinine thing, then in that case we usually do not delay the TURP. Then in that case we usually prefer to go ahead with TURP. But apart from that, there is nothing can anticipate that he will be benefiting with this ADT plus ABI or not. And we have already tried the ADT. In spite of that, he's not getting benefited with 100-gram prostate. I think we should go ahead with channel TURP.
Okay. So before I come to Dr. Pranav and Dr. Sandeep, Moin, is Police or Dr. Advait there? Police had some issue, I think. No, I think. So.
No, sir, they're not
okay.
Joined.
So
Dr.
then
Ashay,
Ashay, are you there? So, so to Dr. Pranav and Dr. Sandeep, so how to do local radiation plus to both the spinal lesions, or only local, and what technique and what dose?
Pranav, yeah, please continue.
I know, Sandeep, you take the question first. I'm sorry.
Okay. See, as of now, we have definitely some evidence of if we are calling this as oligometastatic disease, low volume metastatic disease. So definitely there are evidence of giving prostate directed radiation therapy. We know that from the horror, the Stampede trial. So definitely there is a survival advantage to giving radiation to the prostate. Usually I do follow the 55 gray 20. I'm not very comfortable with 36 gray in 6 fractions weekly once. So 55 gray 20 fractions. But if my urosurgical colleagues do a TURP, definitely I won't rush into it. I will wait for a minimum of 12 weeks for it to heal, and then would take it up. And as of now, we would wait for regarding radiation to the metastatic lesion directed radiation therapy. We don't have any mature prospective data to suggest to that. Plenty of phase 2 trials, and which shows definitely some promise there and advantages there, but it cannot be taken as a standard of care as of today's date. I will wait for the mature results of other prospective phase 3 trials to comment on that. So that would be my take on this.
Okay, Dr. Pranav, your call.
Same, Trinanjan. I'm sorry, I've learned the answer from Dr. Sandeep, but the HORAD and the Stampede trial do show there is not survival benefit, but yes, there is an advantage to giving radiation to the prostate at the primary. Giving SBRT to the 2 spine lesions, because it also helps in cytoreduction, and if we can do it, I don't know, but the evidence still, if it's right now, they are not painful, so maybe let's hope that the prostate radiation helps the bone as well. But then to continue with the ADT, that is for sure, even in oligomers.
So actually, the metastatic directed therapy, the STOMP is a phase 2 trial. It definitely has some benefits. So the phase 3 will come up.
Right.
And yeah, I think it's more like
what endpoints we would be looking, that would
Exactly,
also define.
exactly.
We can
That is
define
also-
our endpoints, and then we can justify to give radiation to the bone lesion
Yes.
as well. Yes, that is how I would think.
And the second is also what I feel, if you ask me, that it's a tricky call that whether we do it or not. If somebody asks me a lower lumbar spine, suppose, or deposit or something in the pelvis, then I feel technically it is not very challenging. Suppose you have to do a cervical and a dorsal as oligomens, you have concerns a lot about spinal cord.
Right.
And when you're not sure what endpoint and data, but if it is at a point where you don't have cord proper, the quota, because that tolerance would be higher, then probably why not? Because I feel for a prostate, forget about this case, if it is purely oligomens, say these are the people who live long. So after 5 years, some practice changing data comes, and then we feel, oh, we had the technology, but we didn't do.
Yes.
That I don't know. I am very against that. Maybe it's very pro doing technology, but I feel if we have technology, judicious use should be there, especially in cases like a disease which is generally has a good survival.
Okay.
But one
so quickly, what you do, Dr. Pranav, will you do the local treatment of by SBRT?
No, the local I'll go with
moderate
hypofractionation. Yes, no SBRT. No, because Gleason's 4+, and it was fixed. I don't know what is the status. We should actually check post
currently.
Therapy.
That's still, not there. Yeah.
But still,
you prefer moderate hypofractionation.
Yes.
Is there some time you wait? Suppose if TERT done today, is there some time interval you'll wait to start?
Yes, I generally wait for a week in our clinical practice.
Right,
a week or 10 days. 10 days.
Yeah, week or 10 days. Yeah, that's good.
So sorry to interrupt, Dr. Trinanjan.
Yeah.
Basically, I want to ask you guys, what exactly are we doing after by doing TURP? Are we helping you out by reducing the prostate, or are we harming your plan after doing TURP? What exactly happens to your plan?
I feel that if it is really this local symptomatic, it should not happen that mid-treatment patient lands up to an urinary emergency, because that anyhow disturbs their quality of life, and eventually all the process you end up doing again. So if you as neurosurgeons are feeling that the size is more, the symptoms are really something that better to do a TERP and then send, then it's okay.
That is understood. No, I'm asking you what happens after TURP. So for example, apart from this particular case, if patient comes to you with TURP and has already been diagnosed after TURP, then what do you change your plan in your radiation therapy, or you continue as same, like you could same?
I would call it same.
I also feel that. Yes.
Okay, so we are not helping you out by reducing the disease.
TURP is something, because it is common, not to this case. If it is post-TERP, at times for high dose, if you're planning SBRT and say suppose for whatsoever reason patient has done TERP, even if for intermediate, then there is a bit caution. The Dr. Vedang has published, he has data post TERP SBRT, but it gets a bit of a caution in that, right, Dr. Pranam?
Yes, and also if I may say, Dr. Saurabh, there is a meta-analysis that says, now again from the surgeon's perspective, that you can go ahead with radical prostatectomy as well for the primary. And
Yeah, I
then
know.
yes, but
But for us, it becomes very difficult to plan radical prostatectomy after TURP. The planes are very
Okay.
difficult. Everything
Right.
is difficult. Bladder neck is difficult to tackle. Anastomosis is sometimes difficult.
Right.
So likewise, I thought for you guys also it would have been difficult to plan accordingly.
For I think moderate hypofractionation would be a per se a
Better
better
option.
a better option in
Yes.
this patient post
In this
TURP.
patient, yes, post
Yes,
TURP, I
rather
agree.
So Pranav and Trinanjan, would
Yes,
you,
sir.
you just said that you will start the radiation immediately within 7 days of TURP. Wouldn't you wait for some more time?
7 to 10 days.
10
I
days.
think
Not for, won't wait for the healing, which usually, but all the literature suggests is still a longer time.
No.
And there is also a meta-analysis which says that if 12 weeks is probably the ideal time. Beyond, if we start early, there is a higher chance of incontinence.
if it is say per primum, TERP done and receive hormone, then we have time definitely. But if it is a botched up case like this, that some treatment given and then in between there's something, then I feel there's also a disease control challenge if you wait this long, because then the local disease is unattended for quite some time, and something which is in spite of hormone not giving much benefit in the local symptom related.
But if you look into the Stampede trial, a lot of patients received the radiation, prostate direct radiation, in a period of 1 year from the time of registration. So if
we lost you somehow, I missed it.
And yeah, if you look at the Stampede registration, a lot of patients received the prostate directed radiation therapy at 1 year from the time of registration.
Yeah, because Dr. Pran.
Without any a change in the basically the results. So why are we hurrying it up?
I feel for the Stampede because the treatment was planned. It was that discussion is pertaining to this. If you otherwise ask, yes, then we have to wait some time. If it is diagnosed on a proper manner, not like this, that some things were done and in between.
Okay.
Pranav?
Sorry, I had gone outside, but I think the Stampede job, Dr. Sandeep, you're saying, was it related to TURP? I don't think so. Was it sort of?
I'm talking about the time frame from where the patient was being registered to the time frame when the prostate directed radiation therapy is given. So if 1 year is to us is a very long period, but that didn't alter the.
No, but how many percentage of patients in the Stampede trial were registered? I'm sorry, I've not gone into that. All the patients were taken up after a 1 year post registration.
No, a lot of patients. If you look, go into it, so they start that it's from 3 months to 1 year, where after the registration,
there's that range in Stampede. Yeah, that is true. There's this range in that.
Yes, 3 months to 1 year.
Because there are a couple of articles which says that yes, maybe 10 days to 14 days or 2 weeks is fine to start off with radiation to the prostate with respect to healing. Again, this Stampede, I'm sorry, I cannot sort of correlate with that.
Okay, so we can skip this part. These are just theoretical. So this is what we are basically discussing, since our medical oncologist colleague could not join. So I was wanting them to talk a bit about the chemo hormonal. So oligomets, we know there's definitely a survival benefit by this. So I will ask, like, maybe Dr. Santosh, Dr. Saurabh and Anirudh sir, do you guys are pro also starting the second line with the beginning in oligomets, or hormone alone is okay to begin with?
You meant to say ADT plus
plus ABI or ENZA, yeah. To start with in oligomets, or ADT alone is okay for you?
So at present, I start with ADT only. I don't add the androgen receptor blockade drugs at the in my practice. But I would definitely be
Dr.
open to
Saurabh and
Yeah,
Anirudh?
correct. I agree. Basically, but literature is moving more towards combined therapy, and
Yes,
standard of care
yes.
has been shifting now. But this is a high risk case, so I think maybe we should try already delayed case. So in such scenarios, maybe I would tend to start abiraterone or maybe ENZA along with ADT.
So
But
Dr.
usually
Saurabh was
in clinical practice.
Trinanjan, can I come in a little bit?
Yeah,
yes,
sure,
please.
sure.
Actually, just to put it like what we're discussing is adding androgen deprivation even in the metastatic oligo. Probably this is the particular subset where we should strongly consider the orchidectomy approach, because you see the basic limitation of adding the ADT for most of the patients would be the financial challenge.
Exactly.
So if we go in with an orchidectomy first approach, then adding abiraterone or ENZA as a first line for the CRPC and the other groups would probably become more easier.
Yeah, that is a very valid point. I would also ask, that's maybe a bit theoretical. Dr. Saurabh was there with me about a month back. We had that GU review. So there is some now articles after the ADT and ABI ENZA for oligomets, and you have only prostate limited disease in your restaging PSMA. So do you operate at that point like a neoadjuvant hormone plus ABI or ENZA, and then you do prostatectomy?
Not really.
See, in neoadjuvant, am I audible? Yeah. In
Yes,
neoadjuvant setting, there is a study which is looking into adding abiraterone also.
Yes.
But unless and until it comes to trials, I don't think so. You would be comfortable doing that.
Okay, your Da Vinci will not be unhappy.
You would not be unhappy because we are controlling the Da Vinci.
Yeah. Not a lighter note. To Dr. Pranav and Dr. Sandeep, if suppose the patient has met medical oncologist since they're not around, and they started also with ABI or ENZA, whatever, and then we are doing local treatment, do we need to stop ABI or ENZA at that point? Because if this is a very practical question to come up to me, and I also had no answer, frankly.
No, sorry, pass. I'm sorry because I have no, I'm sorry because I've not seen such case in practice as well. I'm sorry on the theory part.
Because I don't think, because
theoretically speaking, Ranjan, continuing ADT is not an issue.
Yes,
ABI or ENZA, I really don't know. I really don't know.
Because they're not typical like other drugs where we have to ask people in, say, other non-prostate cancer metastatic scenario, you have to ask at times because they have lot of maybe marrow challenge and all. But both these drugs, though our medoncs colleagues are not around, but I guess can be continued.
Safe, I believe. They're safe.
Yeah, they can be very safe.
Yes.
They can be very safe in that.
Theoretically, they are quite safe. So can be continued with the radiation therapy.
Yes. So I'll skip this theoretical part. This is what we are discussing. And I think this is what they have. Oh, this patient also underwent a robotic radical processing. So I can see Venkat also joined. So all these our rocking neurosurgeon colleagues actually end up operating this. See, that is how it has come. See, someone must have done. That's why this case capsule is given.
Moin has done
it. So since the next questions are mostly related to our medonc colleagues, since they're not around, so we can skip this part actually. So I think we'll conclude this because we are running short of time also. And Vivek, you joined, I think, right?
Yep, I'm here. Can you hear me? Yeah.
Yes, can hear you. So just before we conclude, thank you to everyone. So one last comment for oligometastatic prostate cancer. First, maybe from our three neurosurgeon colleagues, and then from Dr. Pranav and Dr. Sandeep. What do you feel from 2022 onwards for oligometastatic prostate cancer, purely staged, properly diagnosed? What should be the line?
Triranjan, it's very clear that you need to talk about prostate, the diseased prostate-directed therapy, along with metastatic-directed therapy, along with systemic therapy. That's the norm. Now, how things will progress, that only time would say. We have got retrospective data looking into cytoreductive prostatectomy, but we will have probably data coming up looking into how prostatectomy would help in a case of oligomets. Now, if you look at GETUC trial, now what is surprising, when I was reading through, if you look at the GETUC trial, you look at the Stampede trial, they looked at patients who were high-risk localized prostate cancers, but the imaging was conventional.
Exactly.
So what the apprehension is that probably they had oligomets at the time if PSMA PET was used in those studies, and that would encourage us, probably because radical prostate was done in those studies, and that would probably encourage us as surgeons. Radical prostate can be done, but this is a speculation and an extrapolation of the data. As I said, at present, if you look at the evidence, it's radiotherapy for the prostatic bed, radiotherapy for the METs, and systemic therapy. And systemic therapy would be androgen deprivation therapy along with androgen receptor inhibitor therapy. So that's what my understanding is.
Thank you. Dr. Saurav?
So yeah, I completely agree with Dr. Santosh. The same thing. And locally directed therapy, cancer control with radiation therapy, along with metastasis. The only thing which I'm reading nowadays, that the shift of standard of care from ADT alone to one of the agents, that I have not outright started for each and every patient. So that would be the approach for oligometastatic. One question I wanted to ask everyone, this mainly you guys, radiation oncologists. So this oligomets, or maybe like we have two definitions by chartered, low volume, high volume. So which would be better, low volume, high low volume thing, or this oligomets? Because this oligomets, once it comes into picture, we immediately think of doing radiation or radical prostatectomy.
If I can take this, there is no standardized definition of oligometastatic disease.
Correct.
You look at various trials, so that is still evolving. Okay, the current evidence what we have got, the recent analysis, another analysis from the Stampede. So there was around 8 to 10% 3-year overall survival benefit when less than equal to 3 metastatic disease is concerned. So I would put it in that way, that still the practice should be 3 or less metastatic disease, and that would be my take.
Likewise.
Yeah, I feel the low and high volume is typical prostate specific. Oligomets is a broad, any oligomets cancer definition. It has somehow now also started to come out in prostate. Prostate, the thing started low and high volume specifically, I guess, by virtue of PSA and bone versus viscera. So that's how the treatment paradigm evolved. And oligomets, rightly said by Dr. Sandeep and Dr. Pranav, is very confusing from radiation oncology perspective. Our two societies, Astro, ISTRO, has now given a consensus statement, which is again like between 3 to 5, not more than that for sure. Though it is evolving slowly, it will come to be all amenable for treatment and stuff like that. Every field is very technology and industry driven. So eventually these definitions 5 years down the line, if we host this panel, would reach to 10 or 15 also. So
as practicing, sorry. Carry on.
We need to remember one fact is that all these trials based on which we are basically giving our decision today didn't take into account PSMA PET scan.
Exactly. Okay. That is surprising.
It's a completely different ball game when PSMA PET scan comes into the picture. So how do we deal with it? We don't have an answer to that.
Exactly. Yes, Dr.
Yeah, I just want to say, as a practicing urologist, we come across this scenario very commonly, a patient of oligometastasis, and adding upfront anti-androgen or chemotherapy for that matter to ADT, whatever, either orchidectomy or medical ADT. Generally, we are a little bit on the back foot. we generally prefer to add ADT, assess the response, and then maybe later on add any anti-androgen or chemotherapy. However, the site of metastasis will also matter in this case because visceral mets and nodal mets are said to be responding very poorly to only ADT alone. So in such cases, adding upfront something else would be better as compared to a normal bony mets only disease.
Yes, yes, very true. So I think for the interest of time, we'll close here. Thank you everyone for this wonderful discussion. And sorry again, this is my fault. I couldn't put the questions properly in the presentation slides, but it was nice interacting. So we'll come to the last topic. Dr. Vivek Venkat, consulting neurosurgeon and uro-oncosurgeon, he will be discussing on the PROFOUND trial. So I will stop the presentation. Yes, over to you, Dr. Vivek.
Thank you very much, Srinanjan, and thanks to the organizers. So I think, yeah, the slides are there, right? Yeah. Okay, so we just discussed the PROFOUND trial quickly and give an idea of how it is helping our patients and where we can use olaparib in this particular scenario. So prostate cancer, we do know, is very common. In India, it's not as common as it is in the West. It's about 16th, but it is, I think, with more PSA and things like that, we are finding it more and more. And it's usually in the age group of 65 above, but it is also increased in younger age men. So with more and more young men being diagnosed with prostate cancer, the importance of overall survival and quality of life also increases. It is a very complex disease, and in India, still metastatic prostate cancer is probably what we see more often than localized disease. And almost all of these men are ultimately going to become CRPC. And we need to find, different ways, different therapies of helping them prolong their life along with a good quality of life. So that is where probably olaparib and other newer molecular agents will work. So metastatic prostate cancer is actually a heterogeneous disease. 90% of patients will have some aberrant pathways, and about 23% of mutations are identified in the DNA repair pathways, which is where the majority of the research is focused. So the most common of these mutations are the BRCA1 and 2, ATM, PAL, CHEK1 and 2, and RAD51, which are involved in repairing of DNA double-stranded breaks. Of these, BRCA2 is the most frequently altered DNA repair gene, accounting for about 8.6%. And BRCA2 also is a more aggressive type of prostate cancer in those who have BRCA2 mutations. It is often seen in the familial or genetic scenario where there is a significant family history of breast, ovarian, and other tumors as well. So with this in mind, the NCCN actually did update their recommendations and suggested somatic and genetic testing in certain high risk, basically all high risk and above, and at the time of diagnosis. But other guidelines still haven't recommended this. So given the fact that these mutations are common and we have drugs that can target these mutations, so I think that's basically the genesis of the PROFOUND trial. So it was the first randomized phase 3 trial evaluating the efficacy and safety of olaparib versus novel hormonal agents in those with metastatic CRPC. So the eligibility criteria required failure of one prior treatment of basically a novel hormonal treatment that had to be given before olaparib. So there were two cohorts. Cohort A was those which had BRCA1, 2 or ATM mutations, and the other cohort B was a experimental cohort where around 12 other genes were included to see if this would also work. They were all HRR mutation repair genes, but they wanted to see if this would, so it was an exploratory kind of cohort. The primary endpoint was radiographic progression-free survival, and of course, key secondary endpoints were overall response rate, radiographic progression-free survival in both cohorts. The primary was only in cohort A, and time to pain progression, overall survival, safety and tolerability, etc. So these were the two gene panels that were selected based on the Foundation 1 testing, and BRCA1, 2 and ATM are the most commonly mutated genes and the ones which have been best studied, so they were grouped together. So as with any well-designed trial, the baseline characteristics were pretty similar of both the groups. And sorry, which one's going ahead? Okay. And BRCA2, ATM, and CDK12 were the most commonly reported genes that have been seen in this particular cohort. So moving on to the results, PROFOUND did meet its primary endpoint in cohort A, where it more or less doubled, the time to radiographic progression-free survival from 3.5 to 7.9 months, which was a highly significant benefit for patients receiving olaparib in this BRCA1, 2 and ATM group. And across various subgroup analysis, it also maintained its benefit, whether or not docetaxel had been given before, measurable disease, bone-only mets or visceral-only mets, ECOG status, age, across various centers around the world, and across different PSA levels. And it significantly showed a very good objective response in about 33% of patients versus less than 3. So 10 times an objective response in terms of the radiographic measurement of the disease. At interim analysis, olaparib also had a trend towards favorable overall survival. It's not yet reached its final analysis. As of now, this hazard ratio is significant with an overall difference of 3 months. But I think this is still early to, call it as increasing the overall survival. We need to wait for the final results. Similarly, if you combine both the cohorts across the entire population, A plus B, these are now the secondary endpoints that we are discussing. There was a benefit in the radiographic progression-free survival from 5.82 months in olaparib group to only 3.5. So not as strong as cohort A, but overall it's still significant. It's probably all driven by the very, very significant benefits seen in cohort A. Similarly, again, across various subgroups, this was also maintained, and we saw good response radiologically. And even here at the interim analysis, there was again a trend towards overall survival benefit, 17.5 months versus 14.3 months in the control group. So the trend is there for overall survival. There is a definite benefit in radiographic progression-free survival, which is maintained across various subgroups. And so there is some evidence when they analyzed it gene by gene. So the exploratory analysis did show some benefit in the CDK12 group, the CHEK2 group, the RAD51, and the RAD54. But these are very, very small sample sizes, as you can see, 3 and 2 patients, sometimes 7 and 5. So definitely they need further study. And the median duration of treatment with olaparib in cohort A was nearly double that of the physician's choice arm. So definitely now we can probably say that olaparib does work in this particular group of patients who have failed one androgen receptor agent before. Adverse effects are those which are commonly seen and are consistent with its known safety profile, namely anemia, nausea, and fatigue. There was about 4.3% incidence of pulmonary embolism versus 0.8%. So olaparib is not like abiraterone or enzalutamide, which we as urologists, uro-oncologists are also quite comfortable giving. I have never given it personally. I generally refer it to the medical oncologist for olaparib use. So it can be toxic. Anemia is quite common, and it does suppress the bone marrow quite a lot. So I think I leave it to the medical oncologist generally to handle it. It is a pretty effective drug, but there are some limitations of the trial that we need to address. So there was an editorial written about the appropriateness of the control arm, because there is a significant cross resistance between AbbVie and ENZA, whether this was actually a well-selected control group, and less than 50% actually had received docetaxel before. So in the TOPA-PACE study, again for olaparib, but phase 2 trial, all of them had to have chemo before. So there is a little question mark that was raised about this. The use of a crossover design, which kind of confounds whether the overall survival difference is actually meaningful or whether it is due to a delay in receiving alternate therapies in the control group. RPFS is a little softer endpoint. If you look at standard studies for prostate cancer, they use metastasis-free survival or overall survival as the endpoints, especially in a CRPC setting. And the merging of the cohorts was also something that could be addressed. And the benefit in cohort B is really, if you see alone analyze it, it is not very significant. So it's basically driven by BRCA1, 2, and ATM, and to some degree the CDK12. So there is certain limitations, but it does show a significant benefit, and there is a trend towards overall survival benefit. And if that is maintained and if that is reached at the final analysis, I think that will be a very strong signal about the use of olaparib. And what it has actually done is to really stimulate a lot of interest in analyzing genetic signatures for prostate cancer and in doing germline and somatic mutational studies, finding targets to treat. And basically this trial has given a real fillip to all this whole scenario of personalized medicine and targeted therapy, especially in prostate cancer. So this trial does show the efficacy of olaparib, and its side effect profile was pretty similar to what was seen in other cancers. And what I feel is the main importance of this trial is, like I said, the stimulation of further research into what drives prostate cancer and how we can best target it. So thank you very much. And I think we've ended on time. Hello?
Yeah, hi. Thank you, Vivek. I pest you a lot to join and managing the time, but you eventually could make it. Thank you so much. So we had a nice discussion. I would like to thank, there are a few persons to thank from AstraZeneca definitely, and CRSF for taking the challenge of making this meeting successful, especially Moinuddin from AstraZeneca. His persuasive behavior only has led to the successful of this meeting. Otherwise, I was keep on planning and then eventually postponing. This is what happens. And also definitely thanks to Vedang sir. He told that he'll be leaving the meeting. Dr. Vedang Murthy for his all expert comments to begin with. Dr. Ashay Karpe, Dr. Kunjan for their nice talks, and all the esteemed panelists, Dr. Saurav, Dr. Santosh, Dr. Anirudh, Dr. Pranav, Dr. Sandeep Dey. And we hope to catch up soon for some other meeting sometime. So thank you to everyone. Thank you so much.
Yeah, thank you, everybody. Yeah.
Thank you to Dr. Trinanjan.
Thank you.
Yeah.
Thank you, Dr. Trinanjan.
Well done. Bye-bye.
Thank you.